I'm Dr. Molly Lee from the Chinese University of Hong Kong. I'm a thoracic medical oncologist. So today I'm going to talk about a trial in progress that I would like to present. Which is called CITADEL. The whole name stands for Combining Immunotherapy with a TROP2 ADC in early stage resectable non-small cell lung cancer. This is an investigator-initiated multicenter phase 2 study that will be conducted in multiple centers in Hong Kong. So basically in this study, we will enroll patients with stage 2 to 3, according to the AJCC staging 8th edition, resectable non-small cell lung cancer, EGFR and ALK wild type, to receive a perioperative pembrolizumab plus sacituzumab govitecan. So patients enrolled in this study will actually receive 4 cycles of pembrolizumab, as well as day 1 and day 8 sacituzumab govitecan, a TROP2 ADC that is approved in breast cancer, urothelial cancer, active in lung cancer, but not yet approved. This will be followed by a surgical resection and then followed by 13 cycles of pembrolizumab, the design of which is quite similar to the approved KEYNOTE-671 study, which operates on a perioperative pembrolizumab plus chemotherapy. The primary endpoint of this study is the pathological complete response rate. So based on this, we actually hypothesize that this perioperative pembrolizumab plus sacituzumab govitecan will offer a better pathological complete response rate compared to the current standard of care, the perioperative pembrolizumab plus chemotherapy. So based on the statistical design, we hypothesize that this would increase the benchmark pathological complete response rate in the KEYNOTE-671 study from 18% to 38%. So with this statistical design, we will enroll a total of 37 patients in this study. So what is interesting in this study is that we adopted a TROP2 antibody-drug conjugate instead of the traditional platinum-based chemotherapy. As we know, is that the antibody-drug conjugate is a more targeted form of chemotherapy where we can deliver the cytotoxic payload in a more selective setting to the tumor cells. And sacituzumab govitecan is a TROP2-based antibody-drug conjugate. Currently, there are only very few studies that have evaluated or reported the use of ADC in the neoadjuvant setting in lung cancer. So we are certainly looking forward to the data of this study, which evaluated the role of TROP2 ADC in this particular setting. What is encouraging to me is that there are 2 recent reports that was reported in the World Cancer for Lung Conference last week. First of all is that there's the NeoCOAST-2 study presented by Dr. Kina Cascone from MD Anderson, that it was a platform phase 2 study that compared either novel immunotherapy combinations per chemotherapy, and also one study arm of the durvalumab plus TROP2 DXd, the datopotamab deruxtecan plus chemotherapy. And intriguingly, it showed that this dato DXd arm with chemotherapy plus durvalumab arm numerically showed the best pathological complete response rate compared to the novel immunotherapy combination, highlighting that ADC may really play a role in this setting. Notably, the PCR rate was over 30%, which is also much higher than the AGN study that evaluated the use of perioperative durvalumab plus chemotherapy. Second interesting study was presented by Professor Marina Garasino, which reported the first potential biomarker used to predict the efficacy of dato-DXd using an AI-based algorithm continuum scoring system of the TROP2 IHC expression. And because of our study, which also uses a TROP2 ADC, I think there is a great potential of using such of these biomarker prediction algorithm that may help us to predict whom will benefit from TROP2 ADC in the neoadjuvant setting. So with these 2 new studies that are presented, I think there is great potential that would enhance and increase the entire scientific and translational value of our investigator-initiated research. We have started enrollment for around half year, sorry. And so we have been this study is currently actively enrolling, and we feel that the enrollment will continue through around 2025 and will end at around the end of next year. So looking forward to the enrollment as well as the results. So far, we have a few cases who've been radiologically responding quite well to this neoadjuvant combination. But we would need a few more samples to conclude that the pathological complete response is doing better than the historical arm.